Hello everyone, my name is Shaylee Zatz. I am in the Psychiatric Mental Health Nurse Practitioner program at Herzing University, and today I'm going to talk to you about opioid abuse. An introduction to opioids. Opioids are a class of substances that are derived from or act similarly to the substances found in the opium poppy plant. They work on areas of the brain called nerve cells and opioid receptors that block pain signals between the brain and body. Opioids work in the reward system, which is our mesolimbic system, or specifically the midbrain. These substances have a high probability of being abused due to the euphoria that they can produce. They are commonly referred to as opioids, painkillers, or narcotics. Examples of opioids include morphine, heroin, codeine, hydrocodone, oxycodone, and fentanyl. Signs of use include drowsiness, constipation, euphoria, nausea, vomiting, respiratory depression, which can ultimately be fatal. Over time, the patient will develop tolerance and physical dependence, which will increase their risk for overdose and death. So the history of opioid abuse. There were kind of waves that happened, or eras, so I will discuss each of those. Opioids first came to be used in the 1860s to treat soldiers. They were given morphine as a result of being treated and ultimately became dependent on it. In the late 1800s, the heroin era started when Bayer introduced heroin with a claim that it was less habit-forming than morphine, which ultimately was not true. The third kind of wave of opioid abuse, or history of it, came with the restriction of narcotics. From the early 1900s, so 1910s through 1920s, the United States placed restrictions on opioids, requesting formal prescriptions to be written. It was during this time that heroin was ultimately outlawed. In the 1970s came the Controlled Substances Act, which was passed and divided medications into groups depending on their likelihood for abuse. In 1995, Purdue Pharma introduced a form of oxycodone called OxyContin, which was said to be more subtle and less addictive than oxycodone. This led to an increase in prescribing and a whole new generation of patients becoming addicted. Opioids have continued to be prescribed, resulting in additional deaths. In 2017, it was officially declared a health crisis. So this is also the waves of opioid abuse. So the first wave was a rise in prescription opioid overdose deaths that started in the 1990s. And it was a result of overdoses. The first wave of deaths began with increased prescribing practices and providers and was the result of opioids. The second wave started around the year 2010 and was the result of illicit substances such as heroin. The most recent wave started in 2013 and involved deaths related to synthetic opioids like fentanyl. The market for this substance continues to increase, leading it to be found in combinations with other medications such as heroin, counterfeit pills, and cocaine. From 1999 to 2021, over 500,000 people died. Now, over 220 people die daily from overdoses. Now I'll talk about the prevalence and epidemiology of opioid abuse. First, to be said, anyone can be impacted by opioid addiction, whether it be themselves suffering or someone in their family suffering. Over 16 million people are impacted by opioid use worldwide, while 2 million people in the United States are. 3 million people in the United States meet the DSM criteria for opioid dependency. One study found that 1 in 5 adults, or 20%, with chronic pain had taken opioids for pain management within the last 3 months. Other statistics are that women are more likely than men to abuse opioids. Overall percentages of rates increase before decreasing. In 2015, there were 7 deaths per 10,000 people. 25% of women with chronic pain were likely to abuse opioids compared to 19% of men. Use rates increased from 10% in people 18 to 29 to 26% for adults aged 45 to 64 before finally decreasing to 22% of adults aged 65 or older. Deficits in certain neurotransmitters, such as dopamine, can cause people to seek external sources of endorphins, so things that will make them feel happy. So, risk factors and vulnerable populations. Some risk factors for opioid abuse include miscommunication between patient and provider, self-medicating, whether it be to stop them from going into withdrawal or to deal with pain. A fear of withdrawal symptoms is a reason for people to use. Desire for euphoria, so chasing that high feeling. Compulsive use. Illegal diversion for financial gain, so getting opioids from a doctor and then selling them. A young age. A history of personal substance abuse or a familial history of it. Liver, kidney malfunction, people older than 65, and those with sleep apnea. Additional vulnerable populations are those with poor social supports, undergoing psychological stress, those who have psychological trauma or disease, those who use psychotropic substances, those who have been sexually abused, especially pre-adolescents, those with a history of legal problems, a history of substance abuse treatment, and the craving for prescription drugs. Side effects of opioid use. Short-term include drowsiness, slowed breathing, constipation, unconsciousness, nausea, and coma. Long-term effects include muscle and bone pain, diarrhea, insomnia, cold flashes, goosebumps, vomiting, and restlessness. Other signs of opioid use include avoiding time with friends or family, instead opting to be alone, being tired and sad, and having other signs that could be depression, being extremely irritable, nervous, or cranky, experiencing financial hardships due to spending income on drugs, law enforcement involvement, mixing in with different circles and changing friend groups, a lack of hygiene, so not bathing or brushing their teeth, loss of interest in activities that used to be pleasurable for them, quick changing eating habits, either increased or decreased, mood liability, and missing appointments or obligations. Withdrawal from these substances can occur within 3 to 5 days and will be evidenced as cravings, anxiety, irritability, feeling cold, tremors, having abdominal pain, diarrhea with an upset stomach, insomnia and trouble sleeping, and vomiting. So, signs and symptoms of opioid abuse upon assessment. 11 questions should be asked of all patients in accordance with the DSM-5. Patients should be asked if these have occurred over the last 2 months, and positive responses to 2 are indicative of opioid use disorder. The questions are opioids often taken in larger amounts or over a longer period than was intended? 2. Is there a persistent desire or unsuccessful efforts to cut down or control opioid use? 3. Is a great deal of time spent on these activities necessary to obtain the opioid use or recover from its effects? 4. Do you experience cravings or a strong desire or urge to use opioids? 5. Recurrent opioid use resulting in a failure to fulfill major role obligations at work, school, or home. 6. Have you continued to use opioids despite having persistent or recurrent social or interpersonal problems caused by exacerbated effects of the opioids? 7. Are there social, occupational, or recreational activities that you have given up or had to reduce because of opioid use? Number 8. Opioid use in situations where it's physically hazardous. 9. Have you used opioids despite knowledge of it having a persistent or recurrent physical or psychological problem that is likely to have been caused or exacerbated by the substance? 10. Do you have a tolerance, which is defined as either a need for increased amounts of opioids to achieve intoxication or desired effect, or 2, a diminished effect with continued use of the same amount of opioid? And question 11 is, have you exhibited signs of withdrawal, which is defined as stopping of the product or use of opioid that has been heavily and prolonged use, so several weeks or longer, or administration of an opioid antagonist for a period of time. Withdrawal of the substance can develop minutes to several days after use and can include dysphoric mood, nausea, vomiting, muscle aches, lacrimation or runny nose, pupillary dilation, sweating, diarrhea, fever, and insomnia. Physically, doctors will want to look for track marks or scars along veins which suggest injection of drugs. Additionally, they will check for pinpoint pupils, drowsiness, slurred speech, which is consistent with current opioid intoxication. Do they seem to be falling asleep or losing consciousness? Do they have slow or weak or no breathing at all? Are they making choking or gurgling sounds? Is their body limp? Is their skin cold or clammy? And do they have discolored skin, especially in the lips or nails? So, potential for overdose. Risk for overdose can happen when taking it at any dose. And one of the real dangers for opioid addiction and overdose is fentanyl. Fentanyl is 50 times stronger than heroin and 100 times stronger than morphine. It has been linked to both fatal and non-fatal overdoses. Powdered fentanyl looks like other drugs and can commonly be mixed with heroin, cocaine, methamphetamines to be turned into pills. Many people are not aware that they are often taking fentanyl. It can be used in nasal sprays, eye drops, dropped onto paper, or on candies. 2 milligrams of fentanyl is equal to 10 to 15 grains of table salt, which is considered to be a lethal dose. So you can see in the picture on the screen that there's a decent amount of heroin at the bottom, and then you can barely see fentanyl because that is the lethal dose, 10 to 15 grains of what we would use table salt. So a very small amount, meaning it's very, very potent. So what would a care plan be for somebody going through opioid abuse? Medication-assisted treatment is use of Suboxone, naltrexone, or methadone, and a combination with physical or behavioral therapy. So buprenorphine is prescribed and dispensed by a provider who has a drug enforcement agency license and has undergone training to be able to prescribe it, because this can also be abused. Dosing starts off as 2 milligrams per 0.5 into sublingual film, or a 1.4 milligram 0.36 milligram Subzol tablet. Naltrexone is not a controlled substance, so it can be prescribed by any healthcare provider, and it helps deal with cravings. Opioid treatment programs for methadone therapy, and it can be dispensed through an accredited substance abuse approved body, and the starting dose for methadone is 20 to 30 milligrams per day. Things that providers should keep in mind. Buprenorphine and naltrexone block the effects of other opioids taken concurrently, so patients should be educated on this. All three, methadone, naltrexone, and buprenorphine, also reduce cravings. Naltrexone should not be given to pregnant women. Suboxone or buprenorphine is likely to be considered safer than methadone for its overdose risk, given its activity is only a partial opioid agonist and lower potential for respiratory depression. Okay, and naltrexone is available in many forms. It has no abuse potential, so that can be given and is a safer option. Other things that should be included in a care plan: referral to an inpatient level of care if needed, or a partial hospitalization, or an intensive outpatient program. It really is individual to what the patient is experiencing and needing. Cognitive behavioral therapy, talking about why they're using, trying to get to the underlying root, and then educating the patient on, what the therapy is, what the medications are, how to take the medications, what the side effects are. In conclusion, opioids are derived from the opium plant. They can be used for treatment of pain, but require close monitoring as they are highly addictive. Treatment for addiction involves medication and cognitive behavioral therapy. And naloxone is really important in helping fight the opioid pandemic. As when administered to somebody in overdose, it reduces the impact of the opioid in the brain, saving lives. I hope you enjoyed this presentation. Thank you.